Today we're talking about Chapter 4, Special Issues of Women's Healthcare and Reproduction. So some of the issues that face women are preventive healthcare, and what that's saying is that we want to maintain their health. Before they come into the hospital, we want to already be talking to them and helping them take steps to live a healthy life and maintain that healthy life. We'll also be talking about menstruation disorders, pelvic infections, disorders of the uterus and the ovaries, pelvic support disorders, family planning and contraceptives, which you also have a case study, so be sure to look at that, elective termination of pregnancy or abortion, infertility, and menopause. So back in 2010, or actually it started in 1990, the CDC, or the Center of Disease Control, set out some goals to improve women's health. And these are some of those goals related to that. It's one, we want to reduce breast and cervical cancer deaths by increasing the number of females who comply with screening recommendations. Okay, so something you need to know here is that a mammogram initially is only a screening tool. It's not a diagnostic tool. And so what I mean by that is that first, initially, when you send a woman in to get a mammogram, all we're doing is screening. We're making sure that there isn't a problem. Now, if the mammogram comes back and there's a spot on it or something that looks suspicious, we will call her back and we'll do a diagnostic mammogram. With that, that would be where the diagnosis of breast cancer or something else would be made, from that diagnostic mammogram, not from a screening mammogram. Okay. Increasing the proportion of pregnancies that are intended from 51% to 70%. Right now that is huge. 51% of pregnancies are planned. That means 49% are not planned at all. Usually it's oops, I didn't mean for that to happen, or I thought we were using birth control, but maybe we didn't use it right. So we want to increase that to make it 70% of all pregnancies are planned. We're also going to be promoting responsible sexual behaviors, strengthening community compatibility, increasing access to quality services to prevent STDs, and reducing the proportion of adults aged 50 years and older with osteoporosis. So right now we want to bring that down as well, from 10% to 8%. Okay, so health screening for women. Right now we have breast cancer screening, we have pelvic exam and pap smears, vulvar exams, and all of those are different in their recommendations. Right now, breast cancer screening, they used to say that they wanted for women to do monthly breast exams. However, that has recently changed, and the American Cancer Society says that that hasn't really helped with diagnosis. So if you want to do a breast exam every month, then you're more than welcome to. But what they recommend is know what your breasts look like, know what they feel like just normally, and then you can follow up with your primary care doctor, your OBGYN doctor, and have them do the yearly breast exams. And actually, women from 20 to 30 only need a breast exam done every 3 years. So the criteria for that has changed a little bit. Also, we have pelvic examinations and pap smears. Every woman who is sexually active over the age of 21 should have a pelvic exam done every year. A pap smear can be done every 3 years, or if you're sexually active, you have more than one partner, or you have STDs, then they recommend that being done every year. And then a vulvar self-exam is also done during that pelvic examination. Menstrual disturbances. So with amenorrhea, that is the absence of menstruation. There's primary and there's secondary. Primary is for the young ladies who have never had a period before. A secondary amenorrhea would be a loss of menstruation. For some reason it has stopped. And there's several reasons for that. The most common is going to be pregnancy. When you are pregnant, you obviously do not have a period. Some of the other reasons for that could be excess exercise, or your diet change, or some kind of other problem, which we'll get into. Atypical uterine bleeding, menorrhagia, that is heavy or prolonged bleeding at menstruation. Menorrhagia is menstruation bleeding that is normal in amount but occurs irregularly, so it's not a regular thing. And what you have to think of whenever you're thinking of any kind of menstruation, anything like that, it is a sign of health. A healthy menstruation, the presence of regular periods, is a sign of health. Okay, so dysmenorrhea is painful or difficult menstruation. PMS. Okay, we all know what PMS is, right? If you haven't experienced it, you've seen someone who has experienced it. Maybe you say your wife experiences it all the time. Probably shouldn't tell your wife that. But anyways, what is PMS? It is premenstrual syndrome, and it's physical and behavioral symptoms that occur cyclically or in cycles during the last half of the menstruation cycle. Etiology is unknown. Diagnostic criteria, however, you must have signs and symptoms that occur during the last half of the menstruation cycle, so days 14 to 28. The women should be asymptomatic prior to ovulation, which would be days 1 through 14, with at least 7 symptom-free days in a cycle. Symptoms reported can be severe enough to impact relationships, work, and daily lifestyle. So if you're not able to go to work, or you miss work and you have to go home from work because the cramps are too bad, or you get migraines every time, then that is how we would diagnose it. However, diagnosis must be made based on symptoms charted as they occur and not on recalling past events. So that means you have to call your OBGYN, go in, and as they're happening, they'll be able to diagnose that as PMS. So a lot of times PMS is not actually diagnosed. One order of PMS, which is even worse, is PMDD, premenstrual dysphoric disorder. It's a more severe form of PMS. It includes all of the physical symptoms of PMS with additional and more debilitating emotional symptoms. Okay, next symptom we're talking about, or next problem we're going to be talking about, is endometriosis. And this is painful reproductive and immunological disorder in which the tissue implants resembling endometrium, that thing which is inside the uterus, which sloughs off the endometrium, grows outside of the uterus. Okay, so remember, we're thinking about the uterus as that hot air balloon. That is the womb in which a baby is born into. So the rich blood vessels that should be growing inside so that the egg can come and implant into that and grow is all of a sudden growing on the outside. So this can cause horrible pain. It can cause internal and menstrual-like bleeding, which leads to inflammation, scarring, and adhesions. Okay, so you can tell where this it sounds horrible, and it is. It's very, very, very painful. Okay, the next one that we're seeing more of an increase in the recent years more than past, and after we talk about it, you'll probably understand why, is toxic shock syndrome, or TSS. It's a rare illness caused by an exotoxin produced by the bacteria Staphylococcus aureus. The bacteria produce chemicals that cause blood vessels to dilate, which keeps the blood volume in the peripherally reduced. Cardiac output causes hypotension and shock. So anytime you're thinking about shock, automatically you should be thinking about the vital signs. And what do you expect in a shock patient? Heart rate should be going up, but blood pressure should be falling down. Okay, so you're going to have very low blood pressure, but you're going to have a heart rate that is really increased, and that's because of trying to overcompensate. Okay, so that's toxic shock syndrome. And why do we think that we would see more of an increase in that in the recent years? Think about the products that have come out to help women be more comfortable with their period. Super absorbent tampons, right? Okay, so women aren't using those as they're supposed to. They're not using them appropriately. They're leaving them in there, and sometimes they even forget about them. which will cause the toxic shock syndrome. So treatment requires hospitalization, often it's ICU, and you'll be getting IV fluids and antibiotics. Pelvic inflammatory disease. Okay, this is an infection of any portion of the woman's reproductive tract, such as the uterus, fallopian tubes, or the ovary. Often, most commonly is associated with two STIs or STDs, chlamydia and gonorrhea. Untreated pelvic inflammatory disease can lead to scarring, ectopic or tubal pregnancy, and chronic pelvic pain, and it can be life-threatening. So what we're trying to do here with this woman is get her in, get her treated, but then we also have to ask her about any kind of sexual partners that she has and if they have any disorders. This is when we're bringing them in, we're doing education, and we're also treating the partners. So what would some of the risk for PID be? Think about that. Obviously, more than one sex partner, any kind of STDs, unprotected sex, any of those higher risk sexual acts. One more thing, going back, sorry. With PID, in the US alone, there have been over 750,000 cases recorded in a year, and out of those cases, 10 to 15% of the women will become infertile. So even though it might not be a big deal to say a teenager right now that she has this, just treat her, get her the antibiotics, that's all she cares about. What she doesn't realize later is that it can cause her to be infertile for the rest of her life. So as nurses, we're always teaching. We've always got to be teaching and teaching the long-term effect of these things as well. Disorders of the uterus and the ovaries. Okay, so cervical polyps. These are benign tumors that hang on a stem-like pedicle and protrude through the cervical os. So when you think of a grandfather clock, you think of that pedicle. This is a similar kind of shape. And what it is again, it's a benign tumor, so it's not cancerous, but still it's a tumor, and that's going to be scary to any woman who hears that. It's often associated with infection and chronic inflammation. Okay, so what this is on these polyps, it's hanging between the uterus and the birth canal, the vagina. That cervical os is what we also check for dilation when a woman is pregnant. If you're not dilated at all, it's tiny and it looks like a Cheerio basically. But that is where we are looking at. And they're hanging out of that, the womb where the baby is born, the uterus. It's hanging outside of that into the vagina. And I have a picture here in a second. Fibroids, those are benign estrogen-responsive tumors. Okay, so again, it's a tumor, but it's a benign tumor. And these are in the uterine wall, which often regress with menopause. They can be very large. They can cause pelvic pressure and pain and menstrual irregularities, and can be particularly problematic during pregnancy. So there are ways of treating these, but it depends on whether or not the woman wants to remain fertile or if she is all done having kids. If she is all done having kids, then this is often the most cited reason for a hysterectomy. They'll just go ahead and take out all of her female parts. Okay, so here are the cervical polyps, and again, this is the cervical os. That is what you're going to be checking. Well, you won't do any checks, but that is what the doctor checks when he does a vaginal exam. And so putting a speculum up, that is what he would see. Now this is what it looks like from a different view. They're just hanging right outside of the uterus into the vagina. Fibroids, they can be anywhere inside the wall. Now again, I said there are different techniques for this. Now if the woman is through having children, you can come in and the doctor can remove her uterus and give her a hysterectomy. However, if the woman is not through having children and she would still like to have some children, they're able to do a procedure which your book talks about, where they go in, and it's similar to a heart cath, but they will catheterize these arteries right here and decrease or cut off the blood supply to these fibroids, which will cause them to then decrease. Okay, ovarian cysts, they can be follicular or luteal, usually are benign, but they can lead to many complications, which could include hemorrhaging, which can obviously be life-threatening, bleeding out, anything like that is going to be life-threatening. Ovarian torsion, which is the ovary will actually twist, and if the ovary twists, obviously that is going to cut off the blood supply to them, which can cause necrosis, inflammation, infection, things like that. We could also have rupture, they get way too large and they just explode, and bacterial infection leading to septic shock again. Chronic complications, you can have pelvic adhesions, which when you're thinking of adhesion, it's basically like lines just pulling to each other, and that can be very, very painful. It can cause infertility and chronic pelvic pain syndrome. Pelvic support disorders. Okay, so there are 3 types of support inside a woman's pelvis: endopelvic fascia, ligaments, and paired muscle groups of the pelvic floor. Functions like a hammock to support. Okay, so it's very much like a hammock. Now, there's about 2 things that can really cause these supports to lose their function. One is going to be birth. The second is going to be old age, okay? And so they just stop working like they're supposed to. What their function is to hold up the urethra, the bladder, the small intestine, and the rectum, the uterus, and the vagina. Okay, so when they stop working, obviously these things have a tendency to fall, and they can even fall out, which can be very scary as a nurse going in and seeing a woman's bladder in the bed. Okay, so on page 69, you will see different examples of the cytocele, the rectocele, the enterocele, and then a uterine prolapse. So cytocele is when the bladder bulges to the front of the vagina. Rectocele, it's protruding back into the back wall of the vagina. Enterocele is the small intestines kind of jolt downward between the uterus and the rectum. So it's almost like they fall in between the rectum and the uterus, where that should be and be able to expand. Your intestine has fallen down into that. And then uterine prolapse, the uterus is basically fallen out of the vagina. And there's several different treatments for this, and it depends again on woman's age and her preference. For a 98-year-old, we're not going to take her to surgery and give her surgery. The first treatment that we're going to try and encourage the woman to do is Kegel exercises. The next one is she could have a pessary, and that's like a donut-like device. You wash it with soap and water, you dry it off, and then you can put it right back in. So it comes in and out, but it is at a risk for infection if they don't use it properly. And then lastly would be surgery. And of course they're going to try and do the least invasive to the most invasive. Symptoms of this would be all of a sudden you have this heaviness or pressure in the vagina area. It feels like something has dropped or fallen out. And you might find that a patient says that. It just feels like something fell out of me. Well, you lift up the sheets and you look, and sure enough you might see her uterus right there. Okay, birth control. Now I want you to stop. I want you to get out your birth control study guide, and I want you to work through this. You're going to have several resources. Your book is an excellent resource, but also your ATI book. If you'll start on page 2, chapter 1, you'll find that is a really great resource as well. So look through that, and we'll come back to this. Okay. Reproductive life cycle issues. 2 components of family planning. You've got planning and you've got prevention. And so we want to increase that with all of our patients. We want them to plan for their pregnancies, whether they're married or whether it's a teenager, whoever it is, we want them to plan for that pregnancy, not only because there's so many risk factors for teen pregnancies, but also because we want them to be taking the prenatal vitamins early on. We want them to make sure that they're not smoking or drinking or doing anything like that that puts that baby at risk. And of course, prevention. This is when we're going to be talking about birth control. Okay, so planning pregnancy. We want to talk about nutrition. We want to talk about exercises, life changes, making sure that she's not still smoking or drinking, any kind of chronic illnesses or genetic disorders that might put the baby at risk. And of course, medications, making sure that she is on safe medications for the baby. If a woman has a seizure disorder, we have to make sure that she is on some kind of medication that will still prevent those seizures, but that will also not be quite as toxic to the baby. Okay, so preventing pregnancy. There's several natural methods: abstinence or refraining from vaginal sexual intercourse. Of course, abstinence is the only 100% guarantee. A lot of these birth controls have a 99.9% rate or 98%, but abstinence is always going to be the only 100%. Refraining from sex altogether. Coitus interruption or withdrawing. The penis is pulled out of the vagina before ejaculation. Now, there's several problems with this one, and partially is that the penis can actually ejaculate a little bit of semen before you even realize it is. So this is actually not a very good method at all. Okay, fertility awareness methods. Various methods used to anticipate ovulation in the fertile window. They may be used to increase the likelihood of or prevent conception. Natural methods used to anticipate the fertile window. You have the calendar method, you have the basal body temperature method. That's one that is a little bit tricky, but some women are able to do that very well. And what that is you're taking your temperature, and before you ever step foot out of bed, you have to take it the same time every day. And whenever you are actually ovulating, you'll see a slight decrease in your body temperature. Cervical mucus method. You can actually test your mucus in the cervix and see if it is sticky or not. If it'll do that spindle bark test. If it is, then that usually means that you are ovulating. Symptothermal method, standard days method, ovulation predictor test. And those are a couple. Preventing pregnancy. So here we're talking about barrier methods. Okay, so you have your spermicides, your male condom, your female condom, your diaphragm, your cervical cap. There are also hormonal methods, progesterone only pills, hormonal injections, the Depo-Provera shot. This, I believe, is 4 times a year, so that's kind of nice if you can't really remember to take a pill every day. Combined monthly injections, so every month get an injection. You can have hormonal implants like an IUD, a transdermal patch, or a vaginal ring. Warning signs related to using oral contraceptives. So the acronym is ACE, and it's abdominal pain, chest pain, difficulty breathing, bloody sputum, severe headache, weakness, numbness in extremities, eye problems such as blurred vision, double vision, or vision loss, speech disturbances, severe leg pain, or edema. So if you have any of these problems, you don't necessarily have to get off of birth control or oral contraceptives completely, but it would be a good idea to maybe switch. Again, there are IUDs. It's a small T-shaped device that the practitioner inserts into the uterine cavity, and 2 strings hang down from that. You can usually feel them, and that's how the woman is able to check that it is in place every month, and she should check that it is in place every month. I've had several friends who have told me about their babies coming out with an IUD on their forehead, or literally one had it in his hand. It was like his trophy or something. So there are two different types of IUDs. There's a copper-bearing device. It's effective up to 10 years. And then there are also the progesterone-releasing device, which are good for 5 years. The IUD, signs of potential complications, pains, period is late, abnormal spotting or bleeding, abdomen pain, pain with intercourse, infection exposure, abnormal vaginal discharge, not feeling well, having fevers or chills, and of course, again, like I said, you should be able to feel those strings. So if the string is missing, shorter or longer, then it might have moved or got dislodged somewhere, and you'll need to go into your practitioner and have that checked out. Sterilization. So we have female sterilization, which is a tubal ligation or a tubal occlusion. This involves blocking or ligating, tying up those fallopian tubes so that the eggs cannot get released. Non-surgical sterilization, and then ensure permanent birth control system. Okay, so sometimes these things do take a little bit of time to take. Make sure that there is always a secondary birth control measure in there. Male sterilization, of course, there is the vasectomy. Again, like I said, this takes some time to take place. My father-in-law is actually a candidate of a bad vasectomy. It didn't quite take place in the 24 to 48 hours afterwards. No one seemed to know or tell him that, but hey, worked out well for me. Okay, emergency contraceptives. These are the morning after pills, methods used to prevent pregnancy after unprotected intercourse has already occurred. And RU486, the copper ID, of course, you're going to have to go into your practitioner and have that one inserted. Okay, so how do we help the couples choose the right contraceptive method? Of course, it goes back to assessment. Who are you looking at? Who is your patient? Is it a teenage girl who can't really remember where she put her keys, much less to remember every day that she needs to take a pill at the same time every day? Is it a super busy mom who just doesn't have time to take the pills every day, but does really good with a shot maybe, and could give herself a shot every month, or come in every quarter and get a shot? Okay, select the nursing diagnosis, outcome identification and planning. How are we going to implement these things? Teaching them, making sure they know how to use their birth control properly, and then emotional or socio-cultural needs. Many Catholics still do not want to use birth control, so they prefer a natural method, counting days, counting ovulation, using perhaps the temperature method. Okay, so, and then evaluation. It's always important. What are their goals, and are we reaching those goals? Are we having the expected outcomes with those? Okay, abortion. There are many, many different types of abortion, and the first one we're going to talk about is induced abortion, and this is the purposeful interruption of pregnancy before 20 weeks of gestation. So they're actually choosing to abort the baby. They didn't mean to have it. They didn't want to have it. They're going in to the clinic and having an abortion. Then there is a therapeutic abortion, and this is a pregnancy termination performed for reasons related to maternal or fetal health or disease. We'll talk next week and soon about how we're able to do tests now which can predict chromosomal disorders in babies, and we're able to see more health problems before they actually occur. And so a lot of times a pregnancy termination, a therapeutic abortion, will be planned because we either know that this baby cannot survive under these circumstances, or it's dangerous for the mother to continue in this way. Therapeutic abortion is also like tubal pregnancies. The baby is in the tubal, can't think of the word now, fallopian tube. The baby's in the fallopian tube. So that baby will not survive there. They have to be in the womb. Anywhere outside of the womb, the uterus, the baby will not survive. So then we would have to do a therapeutic abortion. And then the last one is an elective abortion, an abortion performed at the woman's request, but does not involve preservation of health. Infertility, this can be a very, very hard disease for not only the woman, but also the man. And whenever they start working up and doing evaluations for a couple, it's usually searching both of them. It typically is not done before 1 year. There has to be a trial of they've tried everything, they've tried for a year, and they cannot seem to get pregnant. That's when we'll start doing kind of an initial evaluation and working it up. It's usually performed by your primary care physician. If the issue is very complex, they'll refer you to a reproductive endocrinologist. And anytime you're referred out like that, anytime you're going to try and do the fertility drugs, it can be very, very expensive. Comprehensive evaluation and diagnostic testing. Timing of diagnostic testing is always in relationship to the woman's menstrual cycle, and it can take up to 2 cycles to complete. Management of infertility, there's treatment of factors that prevent pregnancy. It could be cervical factors, endometrial factors, ovarian factors, or male factors. His sperm count isn't up. Assisted advanced reproductive therapies, ARTs, in vitro fertilization, GIFT, TET, ICSI, all of these things can be very expensive. And there's so many issues that those couples are working through. They're working through a lot of guilt. They feel bad. It could be one side of guilt or both guilt. Either way, we've got to talk through them and make sure that they are dealing with that. And then there's always surrogate parenting. Maybe it's the dad's sperm and another, like the woman is not able to carry the child herself, but they have a surrogate mother who is willing to carry their child. There's many options for that. It could be the woman's egg and the man's sperm, or it could be the surrogate mother's egg and the father donates sperm, and they do it in vitro fertilization that way as well. The psychological aspects, consequences related to infertility often include shock and guilt, isolation, depression, and stress. And a lot of times those couples will have difficulty conceiving. They'll feel very isolated, very different, and it can be very, very hard, a very frustrating process for them. It places a lot of stress on their relationship, and so it's trying to help them work through that. As our nursing care, our major focus is just going to be providing them support, getting them in wherever they need to go, counseling, different support groups, things like that. And then, of course, after diagnosis, giving them additional information, whether they choose to do in vitro fertilization or adoption. It's just getting them the information that they need for that. Menopause is, of course, it signals the end of a woman's reproductive capability. Perimenopause is the time before menopause when vasomotor symptoms start occurring, and those are your hot flashes, your night sweats, your irregular periods. And symptoms may or may not require treatments. And the golden treatment for this, again, is going to be your hormonal replacement therapy. If you have any kind of history of breast cancer, or if you've had breast cancer, or your close family member had breast cancer, then they really recommend that you do not do hormone replacement therapy. It could put you at increased risk for breast cancer. And the reason behind that is that the breast cancer feeds off of estrogen. Okay, moving on. Now it's used to control symptoms but not prevent them. Treatment for hot flashes and sweats, again, hormonal replacement therapy. We're also going to be treating them for osteoporosis. Anytime they're doing those hormone replacement therapies, it can put the women at risk for osteoporosis. Parathyroid hormone, calcitonin, biphosphonates, those are also some different options as well. They can be taking those. Preventive measures include calcium and vitamin D. Any kind of weight-bearing exercises will be helpful with them as well. And then treating vaginal dryness, atrophy. There's several estrogen creams and tablets, suppository things for that, and hormone replacement therapy will also be beneficial. Alright, so study your ATI, Chapter 1, look at your contraceptives, do your contraceptive case study, and I will see you in class.